Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will continue, inshallah, with the second part of the epidemiological study design lecture. And let me first share my screen. Okay, I hope all of you can see my screen now. Okay, so today we will talk more about the two types of observational study design, which is case control and cohort. And then we will delve into experimental study design, and we'll focus more on two types of experimental design, which are randomized control trial and quasi-experimental study. In the last lecture, I have given you an overview of the study design, and we have barely touched the surface of the topic. But this time we will dive a bit more and discuss, I guess, more details about this and talk more about the measures of associations that you can calculate from the study designs. So this is the outline of the lecture today. First, we will talk about case control study and its measure of associations. Second, we'll talk about prospective cohort study and the measure of associations. And finally, we'll jump straight to experimental study design. We'll talk about RCT and quasi-experimental study. This slide is just a quick kind of, I would say, recap of what we have done in the last lecture. I've shown you this slide before. This is basically just the classification of study design. You have descriptive, analytic, and as I have explained earlier, under descriptive, usually you have cross-sectional. Qualitative study can be categorized as a descriptive study design, and under analytic, which basically means that you're trying to find associations or some sort of correlations between your dependent and independent variable. So you have experimental and observational. If you remember, there was another slide that I showed you in the last lecture. In that slide, you would have seen that the classification of study design is actually a lot bigger or a lot larger, or I would say more complicated than this, but this is a simplified version. And since we'll be focusing only on a few types, okay, so we don't have to worry so much at this point about the other types of study. Now, again, I believe I have shown you this slide in the last lecture. So this is just a quick recap. This table shows you the fundamental differences between experimental and observational design. Very quickly, as you can see in the observational study, there is no intervention. Your role as a researcher is just to sit back, observe, and document. Whereas in the experimental study design, you actively intervene, you actively do something, or in other words, you manipulate the independent variable because you want to see the effect on your outcome variable, right? For example, you administer a drug, or you apply certain medical procedures, or maybe you conduct an educational session, and so on. So examples of observation study, again, we have cross-sectional, cohort, case control. We also have other types, actually. For example, case report and case series. For experimental, we also have more than just these two that you're seeing at the table, but for this lecture, we'll focus on these two types, RCT and quasi-experimental. Observational study, in general, is this kind of study is used to find correlations and associations. You don't really say that it can be used for to determine causation, because it does not take time or temporality into consideration. Whereas experimental study usually, gives you a more robust results, in the sense that it can be said to imply causation. Observational study is relatively cheaper and it requires fewer resources, so it's a lot easier to conduct, whereas experimental study requires more resources. And since you are kind of actively intervening and manipulating your independent variable, usually experimental studies come with more ethical concerns as compared to observational study design. Now, when we talk about analytical epidemiological study design, what we're doing is that we're trying to investigate the relationship between, as I said earlier, two types of variable, your independent variable and dependent variable. But sometimes when you read published studies, you might find different terminologies used. And so I'm sharing with you all these terms so that you become familiar with them and you know that these terms are actually referring to the same thing. You might encounter in some papers, they would say exposure versus outcome or risk factor versus disease. Okay, so but basically these are the same thing. When they say exposure, they mean the independent variable, and outcome means dependent variable. The same goes to risk factor. The risk factors are generally the independent variable, and the disease of interest, is usually the outcome or the dependent variable that you want to look at. Now, when we talk about association or correlations, okay, they can usually be in three directions or three types of association. Either the association is increased, which means there is some sort of relationship between your independent and dependent variable. The association can be reduced, right? Which means there is association, but it is protective in nature. Okay, we'll talk a bit more about that in the next slide. And sometimes it can be no association. That means there is no relationship between the two variables that you're looking at. I'll give some examples on the different types of associations later. Okay, so now we look at the first type, which is case control study. And I have given you a brief introduction to case control study in the last lecture. But now I'll give you some more details. So basically, case control study is a study where there are two groups of subjects, two groups of participants, case and control, right? Derived from the name of the study itself. Case refers to individuals with the disease, and controls are individuals who do not have the disease. Of course, when I say disease, it really depends on what your study is, right? If you're looking at a disease, so then that is your outcome. But if you're looking at maybe someone with, for example, who have a history of abuse, right? So that abuse becomes your outcome. So instead of disease, you would say abuse. So basically, when I say disease, that means the outcome of interest. Okay, case control is also known as a retrospective study because the design is that you are looking backward, right? The time direction. You start at the present and you look into the past, as we have discussed earlier. And very quickly, the steps. The first thing you do is that you select a group of cases based on a certain criteria, right? We'll talk a bit more about that later, right after this. And then you select a group of control, right? And what you do as a researcher is that you look back in time because you want to compare these two groups, the cases versus the control, in terms of what? In terms of their exposure status. And then based on that, you will do your analysis and your calculation of measures of association. Now, if you look at this slide, okay, this is, I think I've shared this slide with you in the last lecture, but to recap and to remind you, again, this is how a case control study looks like. You are here, you are the researcher, you are now at the present, and you are looking into the past, right? This is the time direction. You are looking at what has already happened. So you select a group of people who are so-called sick, right? They have the outcome of the disease. and then you select another group of people who are the controls, and then you look into their medical records. Well, it depends. Sometimes you can ask them, you interview them. Sometimes it's a questionnaire. Sometimes it's a review of medical records. And then you looked at their exposure status and you compare between the two groups. Now, selection of cases. When you talk about case control study, there are two aspects of case control which are really, really important. Number one is the selection of cases, and number two is the selection of control. So in other words, you have to be very careful when you select who your cases are. And again, you have to be very careful when you select your control. Okay, let's see why did I say that? When you select cases in a case control study, the first step is to have a case definition. So case definition basically is that you need to list down or lay out your selection criteria to make sure that all your cases that you choose or you select to include in your study really fulfill the definition of case, right? I'll give an example. Okay, for instance, if you say that my cases are diabetes patients, okay, so you first have to construct or develop a case definition where you must define what do I mean by diabetes patient, right? Do I determine diabetes based on clinical symptom? Do I determine diabetes based on lab results, blood results? Or do I determine diabetes based on other diagnostic method? So you have to be very clear about that. And sometimes you will see in many case control studies, the researcher define the case based on a combination of selection criteria. That means they will make sure that the case fulfill certain clinical symptoms, certain laboratory results, and certain diagnostic methods. And only when an individual fulfills all the selection criteria, only then they can be included into the study as cases. So that's why you have to be very careful at this stage. It is very important to define your population at risk, right? So who is your population at risk? Meaning, where are you taking your cases from? Are you taking them from hospitals? Are you taking them from clinics? Are you taking them from registry data? And of course, the second part is to be very careful about selecting your control, okay? And when you select your control, the first criteria that must be in your mind is that, or the first question that you have to ask yourself is that, are my controls comparable to my cases, right? So that's the most important criteria when you select control. You have to make sure that they are comparable. In other words, you must make sure that you're comparing an apple to an apple and not an apple to an orange, for instance. Because if these two groups of people are very different, then your analysis will not give you accurate results. So when you select your control, there is one concept or step that is called matching. So what is matching? Matching is basically selection of controls who are similar to cases, okay, with regards to certain characteristics. For example, age, sex, race, etc. Basically, what you're doing is that when you select the individuals in the control group, you try to match them. You try to make sure that they are as similar as possible to your cases, except for the fact that they do not have the outcome. They don't have that disease, okay? And why are you doing this? Why are you trying to match? Because you want to make sure that the distribution of cases and control is similar. You want to avoid confounding by match factors, okay? That means we try to lessen the impact of confounding factors. And that's why you will always find people saying that comparability is more important in control selection than representativeness, right? So that means when you sample your control group, that is the first criteria. You must make sure they are comparable to your controls. Whether they're representative or not, that is a secondary issue. Okay, so this is an example. Okay, I'll give you maybe 30 seconds to read through this case? Okay, now, as you can see, this is just a very brief scenario. It says, imagine that you randomly select from hospital X, for instance, a group of cases, right, with diabetes, for instance. So you try to make sure as much as possible that your controls, first of all, must not have that disease, okay? They have to be free from that outcome, okay? But they also have to be sort of matched to some extent, okay? Because they have to be similar to your cases, right? So they can be matched by age and sex. Usually these two criteria are the most, I would say, basic ones, okay? So ideally, your controls should also be at risk of that disease. Of course, they must be, when I say at risk, that means they must have the ability to catch that disease or to be afflicted by that disease, but they do not have that disease. Like, another example is that, a very clear example is that if you're looking at breast cancer, for instance, and your cases are a group of females with breast cancer, but if your control is a group of men, then this is your controls are not comparable because men are not at risk. Of breast cancer. Well, of course, that's debatable. Some people say they're still at risk, but what I'm saying is that it's you're just getting two very different groups of people. Okay, or you choose a group of female to compare to a group of men with prostate cancer, for instance. So these females basically are not at risk of that disease, so they cannot be controls. Okay. The second criteria is that ideally they should be sampled roughly at the same time. Okay. And then they should, to some extent, be representative of the non-disease population. Of course, we are not saying that representativeness is not important. All I'm saying is that comparativeness is more important than representativeness, but still we try to make sure that the controls do represent the non-disease population. And of course, the selection of your control group, right, the selection process of your control group is independent of exposure status. Okay, now we will spend some time on analysis. Okay, I think this part is quite important because this 2x2 table, okay, is the, I would say, basis or the is essential or fundamentals of how you can understand or approach any case control and cross-sectional study results. So when you have your results, okay, from case control or observation or cross-sectional study, the easiest way to understand your data is by constructing this 2x2 table. And as you can see here, 2x2 means the first two row is that exposure and non-exposure. That means people with risk factor and people without risk factor. And then you construct two columns. The first column is those with outcome, and then without outcome, disease and no disease. And then here on the last row, the last column, you calculate the total, right? Same goes here. Okay, now once you have this data with you, the next step is for you to calculate the measure of association. Okay, and this is where you will get the odds. Okay, we will maybe, I'm not sure if you have come across this term before, but I'm introducing to you, perhaps for the very first time, the terminology odds. Okay, and the first thing you do is that you count the odds, or I would say odds would mean the probability or the likelihood, right, of the occurrence of a certain event. And so here, first thing what you do is you calculate the odds of exposure among your cases. And then second, you calculate the odds of exposure among your controls. And this is how you do. Okay. A over C means odds of exposure among those with disease. You go back, okay, A over C. So this is exposure, right? A means those who are exposed and have the disease. C is those who are not exposed, but they have the disease, okay? And then second, you calculate the odds or the chance or the likelihood of exposure among non-disease, B over D here. That means those who are exposed but without the disease over those not exposed and without the disease. So eventually, the odds ratio, okay, the overall odds ratio is the first one divided by the second one, and this is the final value that you will get. Some people, they just, kind of memorize this formula when they have the 2 by 2 table. When they want to calculate the odds ratio, they just kind of make sure that they memorize this formula. But of course, as much as it's important for you to know the formula, I also want you to understand how you get to that stage. And this table, I want to repeat that is really important for you to understand it. Okay. Now the interpretation. Okay. So when you say that the odds ratio is more than 1, basically when you calculate odds ratio, you'll find that it's either equal to 1, more than 1, or less than 1. Okay, so if it's equal to 1, right, it's very rare that you get exactly 1 when you have your own data, but assume that, say that you get odds ratio equals to 1, so it means there's no association. Okay, for example, if you're looking at you're studying the relationship between education level and chronic pain, for instance, right? If your odds ratio is 1, that means there is no association between your level of education and your chance or your odds or your probability of getting chronic pain. If your odds ratio is more than 1, that means there is an association, right? I put in bracket the risk because odds simply means the chance or the likelihood of something happening. But in the field of epidemiology, we try to avoid using the word risk for odds ratio because we feel that association reflects better the relationship between your independent and dependent variable. The word risk is usually used more in a different measure of association that we will talk about after this, okay? So we try not to use the word risk, we use the word association instead. For example, you're looking at the association between smoking and chronic pain, if your odds ratio is more than 1, then you can say that active smokers or those who smoke frequently are 3 times more likely to have chronic pain than those who never smoked, for example. If your odds ratio is less than 1, okay, that means there is still an association, but the nature of the relationship is slightly different. It simply means that there is a protective factor there between your independent and dependent variable. So again, another example, if you're looking at the relationship between physical activity or jogging and chronic pain, and you get your odds ratio less than 1, you can say that those who jog frequently or those who actively jog are maybe 2, 3, 4 times less likely to have chronic pain than those who are sedentary or those who do not, engage in physical exercise. So it's important for you to understand when you look at odds ratio that if it's more than 1, that means there is an increased association. Okay, that means that means your independent variable. Okay, those who are that means basically your independent variable is positively associated or is more likely to lead to the dependent variable. If your odds ratio is less than 1, there is a protective association. That means A will cause B to happen less likely, okay? And if it's 1, there is no relationship between the two. Now, some strengths and limitations of case control study. It's also important for you to know this. Why is it that some people or some researchers like to do case control study? So case control design is usually efficient for rare diseases, okay? Or any disease with long latency period. Okay, what does that mean? If you think about it, since you start with selecting individual with diseases, right? If you are interested in a rare disease, right? Logically, you would actually do a case control because it makes your life a lot easier to just go straight to the source, a hospital, for instance, and identify those already having that disease, rather than sampling a whole population, like what you would do in a cross-sectional design, to identify who has that disease, right? So if it's a rare disease, if you sample 1,000 people, there is still a chance that you might not get even one person with that disease. So that is why one of the strengths of case control is that it's more efficient, right? And less time consuming if you opt for case control design. The second strength is that for dynamic populations where follow-up is difficult, whereas of course, if you are looking at a population that is very kind of dynamic in the sense that there are always changes happening, or maybe they move a lot, or it's not easy to track or follow them up, then case control or cross-sectional would be a lot easier compared to a cohort design where you have to follow and track these people from time to time. But case control also has some limitations. Okay, first of all, it cannot establish cause and effect, as we have discussed earlier. It only can establish associations or correlations, right? Because it does not really take time into consideration. What I mean is that you are basically looking back at what has happened, but you do not actually sit down with your subjects and follow them up or wait until the outcome happens. So the second limitation is that case control study is more susceptible to selection recall bias. As you know, as I said earlier, it is a retrospective study because you look back into the past and basically you are asking the patient, right? Or you tell them maybe to answer a questionnaire for them to remember, oh, was I exposed to this? Did I smoke 10 years ago? How many times did I smoke? How many times did I engage in physical activity? So whenever you collect data and that data is based on self-report, there is always a possibility of mistake or error there. So we call that recall bias because an individual is not always able to remember what has happened in the past. Even medical records, sometimes the record is maybe some data is missing or the medical record is incomplete and you go to the doctor to confirm and the doctor may not be able to remember everything that has happened 2 or 3 years back. Of course, case control design does not estimate incidence or prevalence, okay? Prevalence is usually calculated in cross-sectional study, okay? Whereas incidence is usually calculated in prospective cohort design. And finally, case control design cannot determine relative risk, and we'll address relative risk in the next part, which is prospective cohort study. Now, cohort, right? As I mentioned earlier, when someone says just cohort study, usually what he means is prospective cohort. However, there are 2 types of cohort study. There is prospective and there is retrospective. Okay, but prospective is the more widely used, I would say, and the more robust one because prospective cohort looks into the future. The word cohort itself usually means a group of people, right? A group of people with somewhat similar characteristics. There are many names for cohort study. Some people say longitudinal study. Some people say forward-looking or you might also encounter this term incidence study, okay, or prospective study. Why people say incidence study? Because cohort study, prospective cohort design is the most common study design used to calculate incidence, the incidence rate of a certain outcome or disease. Now, there are different types of cohort study. You can maybe say either it's closed or fixed cohort, or open or dynamic cohort. So what does this mean? If your study is a closed cohort, right, it simply means that you have a fixed membership that you have defined at baseline, and you do not add any more study subjects once your study has started. If it's an open cohort, it's the opposite. That means your study is kind of dynamic in the sense that your subjects, your respondents can leave, and therefore new members can enter the study over that study period. Okay, so for example, if you are conducting a study to observe people with a certain risk factor to see whether they maybe get cancer or not in a duration of 5 years, for instance. So if it's a closed cohort, right, and you start with 1,000 respondents, you will not add any members. You will just stick to that 1,000, those 1,000 people until the end of 5 years. So obviously by the end of 5 years, you will have less, right? Because some of them might have migrated, some of them would probably have withdrawn from the study, some of them might have died. But in the case of open or dynamic cohort, you start with 1,000 people and the duration is 5 years. And throughout those 5 years, some of your 1,000 respondents might leave, and you allow them to leave, and at the same time you keep on inviting and including people from time to time. Of course, the analysis or how you handle your data will be more complicated in the open or dynamic type. Okay, so the basic or fundamental idea of cohort study is that you are observing two groups of people over time. Okay, you're looking to the future now, right? Because it's a prospective design. You observe two groups of people over time to determine, or sort of to wait, right, for something to happen, to determine the occurrence of an outcome. And that outcome is usually a disease. It doesn't have to be, but in most cases, it's a disease. And then one group is exposed to a certain variable, right? And the other group is not. Okay. All subjects in a cohort study, when you start sampling for your respondents at the baseline, right? When you start, everybody in your study must be free of the outcome. They cannot have the disease. That means the disease status has to be negative. If any of them has the disease, then there's no point of following them up, right? Because what you're trying to do is basically you want to determine by the end of the study whether this person A and B gets the disease or not. So the first criteria is to make sure that everybody is free from that study at baseline. However, all of them or everyone must be at risk. That means they must have the ability to develop the outcome. Whether they develop the outcome or not, this is what we want to know. Okay, so the researcher starts. Imagine that you are the researcher. You begin with assessment of the study subjects at baseline. After you sample them, you calculate the sample size, you sample them, you get them to your study, you recruit your subjects, and then you assess them. Of course, before recruiting, you would assess to make sure that they're free of the disease. Then only they can be included into your study. And then you also look at the status of exposure. You try to determine who is exposed, who is not. Okay, so basically now you'll have two groups of people. The first group is exposed, the second is not. And both groups are followed up over time. You will be tracking them for a period of time that you will determine. If the study takes 6 months, you will follow them up over that period of time. Some studies take longer, 3 years, 5 years, 10 years. And after that period of time, okay, all subjects are reassessed. That means you follow them up, you meet them again, collect data for the second time, you assess them again to see the outcome status, whether the person develops the disease or not. And at the end of the study, you can calculate incidence and relative risk. So let's see how we do that. I have shared this slide in the previous lecture. Okay, this is just to show you how a prospective cohort study looks like in comparison to case control. So as a researcher, you begin here, this is present, and you're looking to the future. Okay, you are waiting for the outcome to happen, or you're trying to see which of your study subjects will eventually develop the outcome and who among them will not develop the outcome. So if you look here, you have two groups of people now, right? From your whole sample, they are sort of categorized into subjects who are exposed to risk factor. The second group are subjects who are not exposed. You follow them up, okay? And follow up in any prospective cohort study can be done multiple times. In some studies, they might follow up only once, okay? You do data collection baseline, that is mandatory for sure, and then you follow them up. Sometimes the follow-up happens once, sometimes the follow-up happens 2 times, 3 times, 4 times, depending on how you design your study and how long the duration is. And finally, you look at the outcome, who gets the disease and who does not get the disease. Okay, any cohort study, any prospective cohort study will face this major challenge, right? What is this major challenge? We call it dropout or attrition. Okay, what is attrition? Attrition is loss of sampling units, or in other words, loss of study subjects. You lose your respondents with time. Okay, and dropout, okay, can be caused by many factors. Okay, it can be death, right? Obviously, when you look at a group of people and you follow them up over 10 years, for instance, some of them might fall sick, some of them might get the outcome and die, some of them might die due to other reasons, some of them might migrate or relocate. And nowadays, since we rely a lot on internet and phone connection, for instance, you might actually lose connection with them. They change your email, they change your phone number, so you no longer have access to them. And this happens a lot. And some of them simply just lose interest or tell you that I want to withdraw from this study. I don't want to be part of this study anymore after 1 or 2 years of being, in your investigation. So this is very common, and you have to expect dropout or attrition while planning your cohort study. And what is the impact of attrition? It can lead to selection bias. Okay, so what I mean here is that when individuals who drop out from your study have very different characteristics than those who do not drop out, then this will cause your study sample to actually be no longer representative of the general target population. And when you conduct the actual study, you will see that this is a very common problem. It happens a lot. And it does affect your results, but there is a way how to handle this at the not just the study design, but also the analytical stage later. But we're not going to that in this lecture. But this is something that you have to be very aware of, the issue of dropout or attrition and the type of bias that it caused. Now, how do you analyze results that you obtain from a prospective cohort study? First of all, the fundamental idea is the same. You still construct a 2x2 table, okay? And if you see here, the table looks the same. There's no difference between this table and the 2x2 table that we had in the case control study. The first two columns, right? You have this outcome and no outcome. And the first two rows are still the same. Exposure positive, exposure negative, right? And you still put here A, B, C, and D, okay? Right. The difference is what value you use to put into the formula and what measure of association you get out of it, right? So if you see here, A is calculation of incidence and B is calculation of relative risk. Now, when the design is cohort study, right, there are slight differences of how you use the data that you get. And of course, the terminology that you use to name the measure of association that you obtain will be different. So let's see, for instance, if you want to calculate the incidence, right? And if you remember, incidence is a very important measure of association that you can obtain through a prospective cohort design. Incidence cannot be obtained by cross-sectional or case control design. This is something that is very unique and special to the cohort design. So how do you calculate incidence of the disease? There are two types of incidence. So you can get incidence of disease among those exposed. You can get incidence of disease among those who are not exposed. Okay. So incidence of disease among those who are exposed will be A over A plus B. So it will be this one divided by this one, the total. Okay. And the same, if you look at the second one, incidence of disease among those who are not exposed is C over C plus D. Sorry, is this one. Okay, C over C plus D. Then you get, then you get incidence of this and incidence of this. And finally, if you divide this value over this value, you get the relative risk. Okay. Relative risk basically means the risk of an individual with a certain exposure to get the outcome that you're interested in. Okay, so this is the interpretation. Okay. If relative risk, let's look at the last one first. If your relative risk is 1, right, that means the risk is equal in both groups. Okay, so there's no association, right? For instance, again, if you're looking at the relationship between education level and chronic pain, and you conduct a prospective cohort study, and you get 1, then you can safely say that there's no difference in risk of developing chronic pain across different education level. That means it doesn't matter what education level you have, right? The risk of developing chronic pain is the same, whether you have gone to school, whether you graduate from high school, whether you have a PhD or master's, it doesn't make any difference. If your relative risk is more than 1, okay, that means the risk in exposed is greater than the risk in non-exposed, okay? Or in other words, you can say that the independent variable causes higher risk of dependent variable. For example, the risk of developing chronic pain is 4 times higher among active smokers compared to non-smokers. So here you can safely use the word risk because you're using a cohort design, and your calculation is to get a measure of association called relative risk. If you remember, I warned you earlier that if you employ a cross-sectional or cohort, case control design, you will use more of the word association correlation, and we try to avoid using the word risk. Now, if your relative risk is less than 1, that means the risk among those who are exposed is lower, right, than the risk among those who are non-exposed, which simply can be translated into independent variable causes lower risk of dependent variable. So it is a protective kind of relationship. For example, the risk of developing chronic pain is 50% lower among those who jog compared to those who are sedentary. Okay, so you can see that your relative risk is less than 1. That simply means the relationship is there, but it is protective in nature. That means if you are exposed to a certain healthy habit, for instance, your risk of getting a certain disease is lower than those who do not adopt this healthy lifestyle. Okay, some strengths and limitations of prospective cohort study. As prospective cohort design takes time into consideration, and you look into the future, so it can be said to establish cause and effect, right? Another strength is that it can estimate incidence and relative risk, and these two measures of associations cannot be calculated by the earlier study designs that we talk about. And then you can determine multiple outcomes for a given exposure, because when you follow up a group of people for a duration of time, even though your initial objective is just to look at the occurrence of a specific disease, you might also find out that these people can get other outcomes. So this is one of the benefits of cohort, because you are looking to the future and you sometimes do not know what to anticipate, and you might be surprised by some other findings. And of course, it is suitable for rare exposure, because if you remember, when you start at baseline in a cohort design, you try to make sure that everybody is free of the disease, of the outcome that you are interested in, but you try to make sure that you get respondents who are exposed to a certain risk factor, because you are interested in these risk factors. So you can determine whether this group of individuals are exposed to a certain risk factor, which can sometimes be quite rare, that you might not find in other populations. So it is suitable when the exposure is not so common. What is the limitation? As a first one is something that I mentioned earlier, the tendency of this study design to be challenged by attrition, okay, or dropout, which will cause attrition or selection bias. Second is that the study design usually requires a very large sample and a long duration. So it is very expensive to conduct a prospective cohort study, and it's not something easy to implement. You need a lot of resources, a lot of manpower, and of course, a lot of money as well. Third, it is not suitable for rare disease or an outcome that is rare. Because if you're looking at a rare disease, you're sort of waiting for something rare to happen. So this is not the ideal study design for that. If you are interested in rare diseases, you might as well go and conduct a case control study. And of course, the last limitation is that prospective cohort design can be sometimes unpredictable, because external changes may affect the link between exposure and outcome. Since you are sort of sitting there and waiting for things to happen, and you're looking to the future, and the future is uncertain, you do not know what might happen in the next 1 or 2 or 3 months. And these external changes can impact your study or may affect the relationship between the variables that you're looking at. Okay, now the final part, experimental study. So as we discussed earlier, the fundamental difference between experimental design and observational design is that experimental study, from the very name itself, right? Some people call it experimental, some people call it intervention study. So what basically happens is that you as a researcher, you intervene, or you do something actively where you manipulate the independent variable. But any experimental study, usually, not always, but usually has a control group. And it is ideal. It is always better to have a control group, and we will see later why. Experimental studies are usually associated with random assignment. Again, not always, but ideally, if you can do randomization or random assignment of your study subjects into the intervention arm and control arm, that will give you a more robust analysis and results. And finally, one of the, I would say, key features of experimental study is that it has the ability to establish causal relationship. The first type of experimental study, and the most important that we will talk about today, is RCT. Now, what is RCT? So RCT is also a sort of a type of prospective study, right? Because if you think about it, it is a clinical trial, basically, where you introduce a certain drug or a new therapeutic measure, and then you reassess your patient after a period of time to see whether that drug or treatment is effective or not. So in a way, you're looking to the future. You're waiting for something to happen, right? So it can be defined as a prospective study that measures the effectiveness of a new intervention or a new type of treatment. Three key features of RCT that you have to know, okay, is the first one is randomization, second one is blinding, and third one is allocation consumer. And we'll talk about that. We'll try to understand what do these concepts mean. But before we talk about that, I want all of you to know that RCT is a gold standard. Is the gold standard type of study or design or measure, okay, whenever someone wants to evaluate or test the effectiveness of a new treatment. Gold standard means this is the, I would say, the benchmark or the best type of study that gives you the maybe strongest type of evidence when it comes to testing the impact or efficacy of a new treatment. Now, the first key concept that you have to know when you talk about RCT is randomization. It is a very common mistake among my students to use the term randomization when what they actually mean is random sampling. When they talk about conducting cross-sectional or case control study design. But randomization is actually a very specific term that is used most of the time in RCT. And what it means is that another term for it is random allocation, right? And it simply means it refers to the process of assigning participants to different treatment groups. Because when you do RCT, you have two arms, right? You have the intervention group and the control group. So when I say I perform random allocation, or when I perform randomization, it is basically the process of deciding who gets into the intervention arm, who gets in the control arm, but the process has to be random. That means it has to be purely by chance. What you're trying to do is you want to make sure that every individual or every subject in your study has an equal probability or equal chance of being placed in any given group. So if someone is, for example, you are the PI and you like this person, therefore you want to put him in the intervention group, that violates the rule of randomization. When you say random allocation, that means it's kind of unpredictable. Everybody is put either in the intervention or control group purely by chance, and everyone has an equal chance of being in the first or second group. Why do we do this? Because we want to minimize bias. We want to allow for a fair comparison between treatments, and we want to distribute the potential confounding variables evenly across groups, okay? We want to make sure that both groups of people, the one in intervention arm and control arm, are as similar as possible, because we want to lessen or minimize the impact of confounding variables. And this helps you a lot in the analysis stage later. There are three types of randomization. I'm just going to mention them to you. We're not going into the details. Sometimes people perform what is known as simple randomization. There is a different type, which is block randomization, and you can also do stratified randomization. This is just, it refers to different steps or different processes that you do when you try to randomize your study subjects. Now, the second key feature, which is blinding. Okay, I want all of you to know this is also very important. When you conduct a clinical trial, blinding is a very important concept, and it can occur at different levels. In other words, there are different types of blinding. Okay, but before we go into that, what is blinding? So from the word itself, blind, right? It means you cannot see something, or something's being hidden from you. So blinding is the process of concealing the treatment allocation. Okay. So what is treatment allocation? It is whether a participant is receiving the experimental intervention or the control. In other words, a placebo, right? Placebo, when you do an RCT, the control group either does not get anything, right? Or they might get a placebo, which means some sort of a drug or treatment that might appear like the actual medication or drug, but it's actually not, right? Or sometimes they're just given the standard treatment. So blinding is the process of concealing the treatment allocation, or you're basically hiding, or you're not telling, right? Whether a participant is actually getting the intervention, the drug that you're interested in, or are they receiving placebo, right? And blinding can occur to different groups of people, right? You can blind study participants, you can blind the researchers sometimes, and you can even blind other relevant parties involved in a trial. And why do you do that? Because we want to prevent bias in the assessment of outcome. This is very important. People will always ask you, why do you want to blind? And the answer is to prevent bias in the assessment of outcome by minimizing the influence of knowledge about which treatment group a participant is in. Okay. And when you study subjective outcomes, especially, right, where participant or researcher bias could significantly impact results such as pain perception and quality of life, this is where you will see the benefits of blinding most. Because as human beings, we have the tendency to sort of maybe assess someone differently when we know that that person has a certain exposure, right? And it happens more often when the assessment is something subjective and not objective. And that's why blinding helps in this circumstance. And the levels of blinding can be single, double, triple. And what that means is just that which group or who you're blinding. If you just say it's a single blinded study or a single blinded clinical trial, that means the group that is blinded is the participants, just the study participants. They don't know whether they're actually getting the drug or the placebo. If it's double blinded, usually it means it refers to participants and also the researchers. Even the researchers do not have access to the knowledge or the information who is getting the drug and who is getting placebo. If it's triple blinded, triple means three groups of people, that means the blinding extends to even the data analyst or the statistician. Okay, so that means when the analyst looks at the data, there is a way how to hide from the statistician or the data analyst who actually either was exposed or who is getting the drug or who's getting the placebo. So in that way, it will not give the chance, or it will not expose the analyst to any sort of bias because of knowing or not knowing who is receiving what. Okay, the last concept, allocation concealment. This is also important. It is quite similar to blinding, but it's different, and I'll tell you the difference. Allocation concealment is the practice of keeping the treatment allocation sequence hidden from researchers and other individuals involved in the study. This happens usually at the recruitment stage. And why do we do this? It's because we want to prevent researchers from consciously or unconsciously influencing which participants are assigned to which treatment group. The reason why we do allocation concealment is we want to make sure, or we want to protect the integrity of the randomization process. Okay, how is it different from blinding? It is, allocation concealment is blinding in a way, okay, but the difference is that first, when you talk about allocation concealment, you are ensuring that the treatment to be allocated is not known before the participant is recruited into the study. Blinding, on the other hand, makes sure that the patient or the physician is blinded to the treatment allocation after enrollment into the study. So that's the main difference. The allocation concealment actually happens first because it occurs at the stage where you are recruiting or before recruitment. And blinding usually happens after you have recruited or after you enroll your subjects into the study. As we have talked about measures of associations that we can calculate from case control and prospective cohort, in clinical trials, okay, there are generally two approaches when you do analysis of data, okay? I'm not going into the details, but I just want you to know the two types of analytical approach. The first one is they called ITT, intention to treat. The second one is PPA, per protocol analysis. Just very briefly, what is the difference between the two? Intention to treat analysis, okay, is usually the terminology that a researcher or an analyst uses when they include all the patients when they conduct data analysis. That means you include dropouts, people who missed your medication doses, people who don't comply. You include everybody. You do not take only those who actually complete the study or adhere to the study protocol. You don't care. We just include everyone. This is a more conservative approach, okay? And the limitation is that you may dilute the treatment effect, right? Because you're including everyone. And you know that in a study, not everybody complies to the treatment or the protocol. However, the good thing about ITT approach is that you are actually giving a more realistic evaluation in a real world setting, because in real world or in the clinical setting, in the hospital, in the clinic, for instance, you will always come across patients who are not compliant. Not everybody will take the drug according to the right dose. Not everybody will never miss a single follow-up with the doctor. So ITT approach is more realistic compared to per protocol analysis from the name itself, right? Per protocol, that means you really follow exactly what the protocol says. So when you do the analysis under PPA approach, you will include only subjects who adhere to the protocol, and you will exclude everyone else who drop out, who maybe miss some doses, or who do not comply to the rule. In a way, you're being very idealistic, you're being very strict, and you want to include only those who complete the study in the best possible manner. While this is good, this is also very idealistic, okay? And the downside of that is that you will tend to overestimate the treatment effect, because you will you're excluding individuals who do not comply. So you will get very positive results, very optimistic results. This is useful when you want to understand the treatment effect in a very ideal situation, but it is not very useful when you want to generalize your results to the, to the clinical or to the real world setting. Okay, so this slide, I think this is my second last slide. Okay. This diagram is just showing you the other measures that you can calculate in a typical clinical trial or a typical intervention study, especially RCT. You can still get relative risk. If you remember, we calculated relative risk in the cohort study design. Okay, in an RCT, you can also get relative risk. You can get relative risk reduction. Okay, that's triple R. You can get absolute risk. You can get risk difference and number needed to treat. This is usually the most, I guess, widely used measure because it has quite a big impact on public health policy and how to know whether you should proceed with the treatment or not. But I just want you to know that when you conduct clinical trial, these are among the measures of association that you can get. And very quickly, this is the definition. a list of definition of all the measures of associations that I have shown you. There are 5 of them. Okay, I just want to focus on the last one, which is NNT, number needed to treat. What this means is that when you conduct a clinical trial or an RCT, towards the end, when you analyze the data, you can know the number of patients needed to be treated with a specific intervention to prevent one additional adverse outcome. So, for instance, when you conduct a large clinical trial, see the effectiveness of statins, for example, a drug that is used to lower the cholesterol level, then if you get, for instance, NNT of 1,000, okay, I'm just giving an example. So what that means is that you have to give statin, or you need to treat, right, 1,000 people at least with that drug, with statins, in order to prevent one case of maybe additional outcome, and that adverse outcome. It could be high cholesterol, it could be stroke, could be a heart attack. So basically, NNT will tell you, will give you an idea of whether an intervention is cost effective or not, right? Because if the number is so big that you have to give this drug to like 1 million people just to avoid one case of heart attack or stroke, for instance, is that worth it? But if the number is smaller, right, that you can treat a small number in order to avoid one certain number of outcome, then it might sound more cost effective. So this is the NNT usually helps decision makers or policymakers to decide whether it is cost effective or not to proceed with a certain large scale intervention. Now, okay, the last slide for the clinical trial for RCT is the advantages and disadvantages. So as you can see, when you conduct RCT, which is the gold standard measure, I would say, for testing the effectiveness of a drug or a new treatment, what is good about RCT is that it has, I wouldn't say it is completely free of bias, but if you really follow the protocol or the rules for RCT, you will be able to minimize a lot of bias. RCT also has very high internal validity. Okay, it can establish causality, of course, because you manipulate the independent variable in order to look at your dependent variable, and it is also a prospective design. So in a way, it establishes cause and effect, and it has quite strong statistical power. And one reason is because you have performed random allocation of participants in the beginning, so you have sort of taken out a lot of the impact of confounding factors, and you try to make sure as much as possible that both your intervention and control group are similar. However, what the disadvantages are? First, it is very costly and time consuming to conduct an RCT because there's so many rules, and the protocol is usually very strict. So you need a lot of resources, a lot of manpower, and a lot of time, not just for planning, but also to implement the study. There is usually some sort of ethical concern, okay? And of course, there's always a risk of non-compliance. There will always be, participants who won't comply, or maybe who drop out, who do not adhere to the drug that you have administered, for instance. And sometimes the generalizability can be questioned as well. I'm not saying that it's not generalizable at all, but it can be limited depending on how you design the study. And as I said earlier, if you are very strict with the protocol, and if your the drug or the disease that you're looking at and the study population is a very specific, it basically does not really represent the larger population, then your ability to generalize your findings to the to other population or other settings will be very limited. Now, the last type, quasi-experimental study. The quasi-experimental study is it's basically also a form of clinical trial. It is an intervention study. It is almost similar to RCT, but with some differences, right? Okay. The main difference, the main, I would say, gap, or what makes a study be called a quasi-experimental instead of an RCT, is that a quasi-experimental design lacks random assignment. What does that mean? That means you do not perform random assignment, or you do not perform randomization in a quasi-experimental study. For example, in an RCT, you make sure that whether your participants get into the treatment group or the control group is purely by chance. You assign them in a random manner. However, in a quasi-experimental study, you as a researcher, you determine who will be in the intervention group, who will be in the control group. Okay, why does this happen, and in what circumstances do you do this? Sometimes it is not always possible to perform random assignment or to do randomization, and it can be due to factors such as practicality. What is practical or what is not practical, right? It can be due to ethical concern, and it can be due to logistical concern as well. So I'll give you an example. If you are trying to, if there is a new drug or a new surgical procedure, right, that you want to test. So when you do this kind of study, and if there is already some sort of evidence, usually even if a treatment is new, or perhaps it's not so new, but it has not been studied systematically, if there's already some sort of evidence that the treatment is beneficial, right? Or maybe it's a new drug can actually cure a certain disease. Now you want to conduct a study, and you are trying to say that, okay, you will be in this group and this person will be in that group. There's always some ethical concern, because some people can always challenge you and say that, why are you, if you know that someone has that disease already, how can you stop that person from being in the intervention group, because that person needs the drug, right, to cure the disease? So is your concern with being so free of bias in the study more important than your concern for the welfare of the patient or the probability of that patient being cured? So all these questions sometimes come up, and people can challenge you, and people may say that it's not ethical for you, if you know that someone has that disease, to put him in the control group. If you do an RCT where you do random assignment, there is always a possibility that a person who has who has that disease may not benefit from the actual intervention, because there is a chance that he will be put in the control group. So when this kind of situation arises, it can lead to researchers choosing a different design, or it can lead to a researcher deciding to skip the step of random assignment because of such ethical concern. Other issues can be practicality or logistical concern, where if you want to do a large study, maybe it's an education intervention, it's just not possible for you to randomly assign. You just have to, maybe because you don't have enough manpower, you don't have enough time, you have fewer resources, it's just more practical for you to say that, okay, all the teachers in this region will receive the intervention, all the teachers in the second region will receive the maybe standard curriculum, or won't receive any educational intervention, and they will see the outcome. So it really depends on the situation. And I want to let you know that random assignment is not an easy process, and it is not actually possible in every situation. So you will come across many instances where quasi-experimental study is just the best choice that you have, because it's not always, as I said, possible to perform random assignment. Quasi-experimental study has still a lot of advantages, right? For example, it is, as I said, it's less expensive. It's, I wouldn't say it's so cheap as well, but it's less expensive compared to RCT. It is less resource intensive. And sometimes the results can be more generalizable than RCT, because RCTs are usually conducted in very strict and controlled condition. And the circumstances or the conditions of RCT may not necessarily reflect the situation in the real world. Quasi-experimentals is more flexible, more similar, I would say, to the real world situation. And that's why you will find this design more often used to study or to assess the effectiveness of a program or a policy, because it is more practical for real world settings. Some disadvantages of quasi-experimental, and you will see that all these disadvantages that I'm going to mention are mostly related to the fact that you do not perform random assignment or randomization in this study design. So of course, when you don't perform random assignment, the first bias that you will get is selection bias, right? Because you are not able to make sure that the control and the intervention group are similar. It's very difficult for you to determine that from the very beginning. Therefore, this is some sort of selection bias there. And also you as a researcher, you determine who gets the intervention, who doesn't. That exposes you to selection bias. Horpon effect is basically the behavior change of study subjects due to their awareness of being observed. So this is something that you can avoid when you do random assignment or when you do blinding, right? Because when your participants do not know whether they are in the intervention or control group, that effect of behavior change or that awareness of knowing that I'm being observed or I'm getting this drug or I'm not getting the drug is not there. However, when you're not able to do that, when you're not able to randomly assign, and when you're not able to perform blinding, then there's always this psychological impact on your study subjects where they might change their behavior or they might behave accordingly because they know that I'm being observed, I'm in the study, or I'm getting treatment. So I'm supposed to get better, for instance, or I'm not getting this treatment. So why do I bother? There are two other types of biases, historical bias and ascertainment bias. So historical bias is the influence of external events or trends that occur during the study period that can affect the outcome, potentially skewing the results. Okay, this historical bias is usually, I mean, it can happen in different study designs, but it is, if you compare RCT to quasi-experimental, historical bias is more likely to happen in a quasi-experimental study because of external events, right? The influence of what is external to the study or whatever trends that is happening during the study period. And it's very difficult to control that. Now, ascertainment bias, okay, is systematic error when the selection of study participants or data collection methods leads to a sample that is not representative of the target population. Again, so this is okay. This is again, I think, related to the fact that you do not perform random assignment of participants, because when you don't do that, right, it's very easy to have the systematic error, because the way you select your participants or the way you collect data can lead to a sample that is not representative of the target population. So basically, I would say that most of the disadvantages of quasi-experimental study are related to the fact that it lacks random assignment or randomization. I'll give you like a few seconds, maybe 5-10 seconds to read through these types of biases. And I would really encourage all of you to, after this lecture, to read more on these different types of biases to get a better understanding of that. We don't have time to discuss in details, but I just want you to be aware of the types of biases and why are these biases happening. Okay, so this is the last slide. Thank you so much. You can always channel your question as I said, through your public health lecturer. And I will share my email with Dr. Aida so that you can contact me. If you want, please feel free to reach out to me if you have any questions. So thank you so much, everyone. And I hope that was useful. The next lecture will be on other topics. I will look at your syllabus, your curriculum. I forgot what topic is that, but I will inshallah see you all again in my next lecture. Thank you so much, everyone. Assalamu alaikum warahmatullahi wabarakatuh.